Very good morning to all. Today I'm going to present anxiety disorder, ICD10, ICD11 versus DSM5. Moderated Dr. Smith Mehta sir, and ICD10, the name anxiety disorder chapter has one sec. Very good morning to all. Today I'm going to present anxiety disorders, ICD10, ICD11, and DSM5. Moderated Dr. Smith Mehta sir. And ICD10, the chapter has been called neurotic stress and related somatoform disorder. Neurotic stress related and somatoform disorders have been brought together in one large overall group because of their historical association with the concept of neurosis and the association of a substantial proportion of these disorders with psychological causes. In ICD11, the chapter has been called anxiety or fear-related disorder from Black 1 to Black 6 BO. Anxiety and fear-related disorders are characterized by excessive fear and anxiety and related behavioral disturbances with symptoms that are severe enough to result in significant distress or significant impairment in personal, family, and social, educational, occupational, and other important areas of function. The clinical presentation of anxiety and fear-related disorders typically includes specific associated cognitions that can assist in differentiating among the disorders by clarifying the focus of apprehension. In DSM5, the chapter has been called anxiety disorders. The fear is the emotional response to real perceived as imminent threat, whereas anxiety is anticipation of future threat. Agoraphobia in ICD10, the code has been called F40.01. In criteria A, there is marked and consistently manifest fear in our avoidance of at least two of the following symptoms has been present, like a situation has been present. In crowd area, public places, traveling alone, and traveling away from home. In criteria B, two of the following symptoms should be present in feared situations, like commencement of the disorder. One of the four symptoms should be present in the following. That has been autonomic arousal symptoms like palpitations, pounding or accelerated heart rate, and sweating, shaking, dry mouth. Chest and abdomen symptoms, difficulty in breathing, feeling of choking, chest pain or discomfort, nausea or abdominal stress. Example, churning in stomach. Symptoms involving mental state like feeling dizzy, unsteady, faint or lightheaded, feeling that objects are unreal, like derealization and depersonalization, fear of losing control, fear of dying, hot flashes or cold chills, numbness of tingling sensation. In ICD11, agoraphobia is characterized by marked and excessive fear of anxiety that occurs in other places like shops, theaters, standing in line. The situations are actively avoided, entered only in under specific circumstances such as in the presence of a trusted companion or endowed with intense fear or anxiety. In DSM-5 criteria A being in enclosed 5 places, uh, the fear of anxiety or avoidance persistently lasting 6 months or more. The symptoms may worsen in social, occupational, other areas of functioning. In the medical condition like example, inflammatory disease or Parkinson disease, anxiety symptoms more excessive. Symptoms not explained better in another medical conditions such as specific phobia, situational type, not relatively exclusive to OCD, perceived defects or flaws in body dysmorphic disorder, reminder of traumatic events in PTSD, and fear of separation. Diagnosis and at least 2 of the following situation in criterion A, duration in 6 months. ICD10 criteria C, agoraphobia, like significant emotional stress caused by maybe anxiety symptoms and the individual concerned, it's excessive or unreasonable. In criteria D, symptoms are restricted to predominant in the feared situations or contemplation of the feared situations. Exclusion, like criteria A, symptoms not the result of delusions and hallucinations and schizophrenia, other related disorders, mood disorders, and OCD, are cultural beliefs. The presence or absence of panic disorder and majority of agoraphobic situations specified by using fifth character. There is a two criteria like F 40.0 without panic disorder. Severity may be counted by degree of avoidance and account of specific cultural setting. And F 40.01 with panic disorder, severity counted by number of panic attacks. In DSM-5, like prevalence 1.7%, it is a American Psychiatric Association prevalence. Adolescents and adults have a diagnosis of agoraphobia. Females are twice experiencing agoraphobia. It's occur in childhood, later incidents peaks develop in adulthood. Development and course, mean age of this disorder 17 years, initial onset before 30 years. There is this after 40 years, proceeding with panic disorder 25 to 29 years. Risk factors like temperamentally, like behavioral inhibition and neurotic disposition, highly related with agoraphobia, environmental negative events in childhood, like stressful events, being attacked or mugged are associated with agoraphobia. There is a reduced warmth and increased overprotection in the family. Genetically, there is a heritability of the heritability for agoraphobia is 61%, and gender-related diagnostic issues like females have different comorbid disorders and males has higher rates of comorbid in substance use. Social phobia, ICD10 code like F40.10, either of the following symptom present, like a marked fear of being focused attention, marked fear of being focus of attention or of a situation which there is a fear of behaving embarrassing or humiliating way. These fears are manifested in social situations such as eating, speaking in public, encountering known people in public, or entering or enduring small group situations. Two of the anxiety symptoms present in F40.0 criterion B, like otherwise there is a answer of the disorder together at least one of the following symptoms should be present, like blushing or shaking, fear of vomiting, urgency or fear of micturition or defecation. Significant emotional distress caused by the symptoms by the avoidance, and the individual recognize that these are excessive or unreasonable. Symptoms are restricted to or predominate in the feared situations or contemplations of the feared situations. Exclusion criteria like delusions and hallucinations, organic mental disorder, schizophrenia, and other related disorders, mood disorders, and OCD. In DSM-5, there is a marked fear or anxiety about one or more social situations in which the individual exposed to possible scrutiny by others. The social situation almost always provoke fear or anxiety in children, like fear or anxiety may be expressed by crying, temper tantrums, freezing, clinging, and shrinking or failing to speak in social situations. Fear of anxiety persistent for 6 months causes for impairment in functioning, not attributed to psychological effects or substance. And DSM-5, like associate features supporting diagnosis, like individuals may be excessive submissive or less commonly high controlling during conversation, shows overtly rigid body posture, maintain inadequate eye contact, speak with short voice. Risk factors like traits that predispose individuals such as behavioral inhibition, fear of negative evaluation, childhood maltreatment, and adversity may be present. In children with high behavioral inhibition are more susceptible to environment influences such as socially anxious modeling by parents, like genetic, like a first degree relatives, two-fold of 6 times having chances of social anxiety disorder. The syndrome of Tijin-Pio fulfilling the criteria for social anxiety disorder. Social anxiety disorder is associated with elevated rates of school dropout and with decreased well-being, employment, workplace productivity, socioeconomic status, and quality of life. In ICD-11, social anxiety disorder code like 6B04, characterized by marked and excessive fear and anxiety that consistently occur one or more social situations, such as social interaction, example, having a conversation or being awkward giving a speech. There may be impairment in like personal, social, educational, occupational, and other important areas of specific phobias. In ICD-10 code F40.2, either of following symptoms may be present: marked fear or specific object or situation not included in agoraphobia and social phobia. Marked avoidance of a specific situation or object not included in agoraphobia and social phobia. Among the most common object situations are animals, bats, insects, heights, thunder, flying, and small enclosed places, dentists, and hospitals. Symptoms of anxiety in the feared situation defined in F40.0 criterion B must have been manifest sometime since the onset of the disorder. And symptoms like emotional distress caused by the like individual recognize that these are excessive or unreasonable. Symptoms also feared situation contemplation, like specific phobia symptoms such as follows: animal type, natural forces, blood injection and injury type, situational type. In DSM5, there is a marked fear or anxiety symptoms present persist 6 months or more. Criteria order related to phobia like animal, natural and environment, blood injection or injury, situational and other. Approximately 75% individuals with specific phobia fear more than one object. Prevalence in APA like 7 to 9%. Risk factors like temperamentally negative affectivity and environmental like behavioral inhibition, risk factors of other anxiety disorders, parental over protectiveness, and parental loss and separation, physical and sexual abuse, traumatic events. Individuals with a specific phobia are up to 60% more likely to make suicide attempt than are individuals without the diagnosis. In ICD-11, social anxiety disorder, like specific phobia called social anxiety disorder 6B03. Specific phobia is characterized by a marked and excessive fear or anxiety that consistently occurs when exposed to one or more specific objects or situations. Inclusions, the symptoms also persistent like last several months and may make some impairment in areas of functioning, and inclusions like simple phobia, acrophobia, claustrophobia, and exclusions like body dysmorphic disorder and hypochondriasis. Panic disorder in ICD-10 code F41.0, episodic paroxysmal anxiety. Individual experiences recurrent panic attacks that is not consistently related with specific situation but occur spontaneously. Panic attack characterized by discrete episode of intense fear or discomfort. It starts abruptly, it reaches maximum within a few minutes and lasts at least some minutes. 4 of the following symptoms like autonomic arousal symptoms present, like palpitations, already discussed, and chest and abdomen symptoms also present, and general symptoms like hot flashes or cold chills and numbness or tingling sensation also present. And inclusions like organic mental disorder and psychotic disorder, mood disorder, and spontaneous disorder. There is a 2 criteria has been followed in ICD-10 like F41.00. If the panic disorder moderate, at least 4 panic attacks in a 4-week period. F41.01, at least 4 panic attacks per week over a 4-week period. Panic attack, it is called panic disorder severe. In DSM5 code 300.01, there is an abrupt onset occurred from calm state or anxious state within the following symptoms. These are the 12 symptoms presented in panic disorder in DSM5 criteria. Culture specific symptoms like example tinnitus, neck soreness, headache, uncontrollable screaming or crying may be seen. One of the following attack has been followed by 1 month period or 1 month, more than 1 month period. Persistent concerns like or worry about their additional panic attacks or their consequences, significant maladaptive changes in behavior related to other attacks. And disorder not the panic disorder not attributable to the another medical conditions, example hyperthyroidism and cardiopulmonary disorders and substance abuse. Disturbance is not better explained by another medical disorder such as social anxiety disorder, phobic disorder, OCD, post-traumatic stress disorder, and separation anxiety disorder. In moderate criteria like 1 attacks per week, severe daily, weeks or months. Like less frequent attacks criteria 2 per month with 4 or more list of 13 physical or cognitive symptoms. In DSM5 criteria, associated feature and supporting diagnosis like unexpected panic attack is a nocturnal panic attack, waking from sleep in the state of panic, which differs from panicking after fully waking from sleep. In US, this type of panic attack occur once in 1 quarter, 1/4 of 3 in individuals with panic disorder. Individuals with panic disorder often anticipating with catastrophic outcome. There may be concerns with stressors, substance use to control panic attacks, extreme behaviors to control panic attacks. In US and European countries, prevalence like 2 to 3% in adults and adolescents. Females more affected than males. Panic disorder low in before 14 years and gradually increase in females during puberty and adulthood. Risk factors like temperamentally, negative affectivity, anxiety sensitivity, history of fearful spells, separation anxiety in childhood. Environmental risk factors like childhood physical abuse, smoking is a risk factor, interpersonal stresses related to the physical well-being, negative experiences with substances, disease or death in the family. In genetic vulnerability like multiple genes confer vulnerability to the panic disorder. Panic disorder emphasizes the amygdala and other related structures, offsprings of parents with anxiety, respiratory disturbances like example asthma and associated with panic disorder. In cultural syndrome like attacchi de nervios, like attack of nerves, Khial attacks in Latin Americans and soul loss among Cambodians. Furthermore, refer to the glossary of cultural concept of distress in the appendix DSM5 criteria. Gender related, like some evidence found related to the sexual dysmorphism associated with between panic disorder and catechol O methyltransferase, COMT gene in females only. Panic disorder with 14 months history, risk factors of suicide. None of the laboratory findings considered diagnosis of the panic disorder. Panic disorder associated with high levels of personal, social, occupational impairment and strongest with agoraphobia. Individuals with this disorder found results absent from school, dropping out from school, occupational results like unemployment, impairment in duties, severe conditions associated with poorer quality of life and such maybe disability. In ICD code like 6B01, symptoms like panic disorder symptoms presented as well as there is a significant impairment in persist like personal, family, social, educational, occupational, and other areas of functioning. Symptoms are not manifest in another medical condition under substance abuse. Exclusion, panic attack. Selective mutism in ICD 11 code 6B06. Selective mutism is characterized consistent. Sorry, okay. ICD 11 6B06. Selective mutism is characterized consistent selectivity in speaking, such that a child demonstrates adequate language competence in specific social situations, typically at home, but consistently fails to speak in others, typically at school. The disturbances last 1 month, is not limited to the first month of school and is of sufficient severity to interfere with educational or occupational achievement or with social communication. In DSM5 criteria, like DSM5 diagnostic criteria code 313.23, there will be a like a consistent failure to speak in specific social situations in which there is an expectation for speaking. Example, school, despite speaking in other situations. The duration of the disturbance at least 1 month. Other than that, there is a disturbance not better explained by communication disorder. Example, childhood onset dementia disorder, and does not exclusively during the course of autism spectrum disorder, schizophrenia, and another psychotic disorder. Generalized anxiety disorder, ICD-10 code F41.1. There must be at least 6 months symptoms of prominent tension, worry, feelings of apprehension about everyday events and problems. At least 4 of the following symptoms must be present, like the symptoms already discussed here, like autonomic arousal symptoms, symptoms involving chest and abdomen, symptoms involving mental state, general symptoms. And there is a separate criteria added, like symptoms of tension, like muscle tension or aches and pains, restlessness and inability to relax, feelings keyed up, and a sensation of lump in the throat or difficulty in swallowing. Other non-specific symptoms like exaggerated response to minor surprises being started, difficulty in concentration, maybe going blank, persistent irritability, and difficulty in getting to sleep because of worrying. The criteria does not meet in panic disorder and like phobic anxiety disorder, OCD, and hypochondriasis. Anxiety disorder is not due to physical disorder or substance abuse. In DSM5, generalized anxiety disorder code like 300.02. There are following 6 symptoms like anxiety or worry persist days, not for at least 6 months. Results impairment in social, occupational, and other important areas of functioning. This is not attributable to other medical conditions as well as substance abuse, not related to another mental disorder. Many individuals with the GAD also experience in somatic symptoms and exaggerated status response. Other conditions may be associated with like irritable bowel syndrome, headaches. In US prevalence, 0.9% among adolescents and 2.9% between adults. And the symptoms in GAD like maybe wax and wane across the lifespan. Rates of full remission is very low, maybe diagnosed with over-diagnosed with children. Risk factors in temperamental risk factors like behavioral inhibition, negative affectivity, and harm avoidance. Environmental risk factors like parental overprotection, otherwise no environmental factors. And genetically, like 1/3 of the risk factors, generalized anxiety disorder is genetic overlap with the risk of neuroticism. Culture related like somatic symptoms predominate in the expression of the disorder. Gender related like frequently in females than males. They were confined with unipolar depression, whereas males in comorbidity substance abuse. In ICD-11 code 6B00, symptoms persist at least several months, manifest by either general apprehension. Example, free floating anxiety. Otherwise, there is impairment in other areas of functioning and not manifest in another medical conditions and subject. Obsessive compulsive disorder, ICD-10 code F41.1, obsession. There is a predominantly in obsession and compulsion present at least 2 weeks. Obsessions like ideas, doubts, thoughts, and images. Compulsions like it acts and the following features like patient are not imposed by external forces, repetitive or unpleasant obsession or compulsion acknowledged. Patients may be try to resist them, and there is not a pleasurable obsession thoughts or compulsion. Results of lacking in social and individual functioning with presence of wasting time. Exclusion criteria like psychotic and mood disorders, and there is a separate criteria in ICD-10 obsessive compulsive disorder like predominantly in obsessive thoughts and ruminations, F42.1, predominantly compulsive acts, F42.2, mixed obsession thoughts and acts, and F42.8, other obsessive or compulsive disorder, F42.9, OCD unspecific. In DSM5 criteria, the DSM5 code like 300.03, recurrent obsessive thoughts and images marked by anxiety or distress. Distress made like social and occupational and other areas of functioning. This is disorder not attributable to the other medical condition and mental disorders such as and substance abuse. There is a separate criteria followed in DSM5 like with good or fair insight, Individual partially recognize the condition, and with poor insight, individual thinks the condition probably true, and with answer insight, relational beliefs completely convinced that OCD beliefs are true. Tick related has current as past history of tick disorder. Risk factors like temperamentally. Not part of the criteria. Okay, sir. Okay, sir. And ICD11 B1 6 B2 like features like obsession and compulsions most commonly for more than 1 hour per day. The symptoms will be appear more than 1 hour per day. Obsessive compulsive disorder with fair to good insight. All the symptoms present individual when highly conscious may demonstrate to no insight, and the obsessive compulsive disorder with poor to absent insight. The lack of insight exhibited by the individual does not vary markedly as a function of anxiety level. Obsessive compulsive disorder unspecific. Body dysmorphic disorder, DSM5, code 300.03, and the symptoms will be like preoccupations with one or more perceived defects or flaws in physical appearance that are not observable or appear sight to others. Individual performed repetitive behaviors like mirror checking, excessive grooming, skin picking, reassurance seeking, or other mental acts like comparing his or her appearance with others. Preoccupation results distress impairment in normal day-to-day functioning. Preoccupation better not explained by concerns with body fat or weight, and individual who meet the diagnostic criteria of eating disorder. This has three separate criteria like for diagnostic features like with good insight, with poor insight, with absent insight, relational belief. Disorder associated with childhood neglect and abuse related to with first degree of OCD. Later term like Shubokyofu, the phobia of deformed body. Now ICD11, the code will be like 6B24. There is a 5 symptoms present related to the body dysmorphic disorder. Onset not mentioned in this disorder. Exclusion criteria like anorexia nervosa, bodily stress disorder, concern about body appearance, criteria like with fair to good insight, with poor or absent insight, or unspecific. Coding disorder, DSM5 criteria like code will be like 300.7. Persistent difficulty discarding or parting with possessions regardless of their actual value. This difficulty is due to a perceived need to save the items and to distress associated with discarding them. The difficulty is discarding the possessions results in the accumulation of possessions that congest and clutter active living areas and substantially comprises their intended use. The hoarding causes clinically significant distress, impairment in areas of functioning like social, occupational, and other important areas. Hoarding is not attributable to another medical conditions such as brain injury, cerebrovascular disease, Prader-Willi syndrome. And the hoarding is not better explained by the symptoms of another mental disorder. It has 3 separate criteria like good insight, poor insight, absent insight, or delusional belief. 80 to 90% individuals presented with excessive acquisition, and common features include indecisiveness, perfectionism, avoidance, procrastination, difficulty planning and organizing tasks, and distractibility. Twin studies indicate that approximately 50% of the variability in hoarding behavior is attributable to the additive genetic factors. ICD11 criteria says that hoarding disorder is characterized by accumulation of possessions due to excessive acquisition of difficulty discarding possessions regardless of their actual value. It has 3 criteria like with fair to good insight, with poor to absent insight, or unspecific. Trichotillomania, DSM5 criteria 312.39. There is a recurrent pulling out of one's hair resulting in hair loss. Repeated attempts to disease or stop hair pulling. The hair pulling causes clinically significant distress, impairment in social, occupational, or other important areas of functioning. The hair pulling or hair loss is not attributable to another medical condition. The hair pulling is not better explained by symptoms of another mental disorder. Hair pulling may be seen in infants, and this behavior typically resolves during early development. Onset of hair pulling in trichotillomania most commonly coincide with like follow the onset of puberty, and the disorder commonly seen in individuals like OCD, first degree relatives in than the general population. Most individuals with trichotillomania admit to hair pulling. Thus, dermatopathological diagnosis is rarely required. Skin biopsy and dermoscopy, like a trichoscopy of trichotillomania, are able to differentiate the disorder from the causes of alopecia. In ICD-11, like hair pulling may occur in brief episodes scattered throughout the day or in less frequent but more sustained periods. The symptoms resulted in significant distress in areas of functioning. Inclusion criteria like compulsive hair plucking, and exclusion criteria will be like stereotyped movement disorder with hair plucking. Excoriation disorder like DSM5 code like 69.8.4, the recurrent skin picking resulting in skin lesions, repeated attempts to decrease or stop skin picking. The skin picking causes clinically significant distress or impairment in social, occupational, other important areas of functioning. The skin picking is not attributable to the physiological effects of a substance. Example, cocaine. Another medical conditions such as example, scabies. The skin picking is not better explained by symptoms of another mental disorder. Although individuals with excoriation disorder may present at various ages, the skin picking most often has onset during adolescence, like commonly coinciding with following the onset of puberty. In ICD-11, excoriation disorder is characterized by recurrent picking of one's own skin, leading to skin lesions accompanied by unsuccessful attempts to decrease or stop the behavior. Like inclusions will be like skin picking disorder, exclusions like stereotype movement disorder, acute excoriation of skin, chronic excoriation of skin. Substance medication induced obsessive compulsive and related disorder. There is separate criteria added in DSM5. Obsession and compulsions, skin picking, hair pulling, other body focused repetitive behaviors are other symptoms characteristic of the OCD symptoms, like predominantly seen in the clinical picture. And there is evidence from the history, like physical examination or laboratory findings of both will be present. And the symptoms in the criterion A developed during or soon after substance intoxication or withdrawal or after exposure to a medication. The involved substance medication is capable of producing the symptoms like in criterion A. There is a disturbance in not better explained by obsessive compulsive and related disorder that is not substance medication induced. Such evidence of independent obsessive compulsive related disorder could include the following. The symptoms will be persistent like more than 1 month, about 1 month or more than 1 month after the cessation of acute withdrawal or severe intoxication, and there is other evidence suggesting the existence of an independent non-substance or medication-induced obsessive-compulsive related disorder. Example, history of recurrent non-substance medication-related episodes. There is a disturbance that does not occur exclusively during the course of a delirious state, and the disturbance causes clinically significant distress, impairment in there are areas of functioning like social, occupational, and important areas. There is a separate criteria called like other specified obsessive compulsive related disorder. This category applies to presentation in which symptoms characteristic of OCD symptoms like caused significant interest, impairment in the areas followed by and predominant but not meet the criteria will not be fulfilled, and in the diagnostic clause. Unspecified OCD related disorder like the category applies to presentations in which symptoms characteristic of an OCD symptoms and related disorder that cause clinically significant distress, and impairment also seen in the social and occupational other areas of functioning, and it is also does not fulfill the criteria and related disorder to diagnostic clause. Obsessive compulsive disorder due to another medical condition. There are OCD symptoms will be presented as well as like
OCD DSM5
yes.
So OCD and anxiety disorder DSM5.
No, sir. So there is a there are
OCD was anxiety disorder in ICD, but in DSM5 or ICD10, so it should be under so that difference you should have presented. Okay, ICD11, ICD10 had OCD, anxiety, DSM5 doesn't have ICD11. So that should have. So detail में सारा difference among all the three systems we need to discuss.
In ICD11, there is a new chest. Okay. One.
What is there in anxiety disorder? Describe under anxiety disorder DSM5 and ICD11. That I think we need to discuss.
PTSD, post-traumatic stress disorder, like in ICD10, like individual exposing stressful event or situation by exceptionally.
PTSD is there in anxiety disorder. In ICD10, it's there. In other
Yes, sir.
DSM5.
Yes, sir.
Oh, it is under anxiety disorder. So that only that should have been explained. You have actually given us a template what is present in ICD11. All these subheadings which are common, you should have explained the differences. और जो uncommon है इधर उधर रख दिए गए हैं बस वो उधर उधर रख दिए गए हैं. आपका क्या बचे है? Dissociative disorder again. ICD11 के अलग है. The idea being कि older diagnosis system how it is different, the viewers are how it is different from older. The common diagnostic criteria है, उनको उनका differences और जो हटा दिए गए हैं why they were removed. I think this would have made more because other subsections will maybe come later. And that day also I told you why you were actually reading all the three criteria. That day I think you didn't get my point. Whatever is common in one, all the three criteria, you can mark it and read it from only one criteria. Highlighted key dysfunction is common in all this. You need not read it dysfunction 3 times. Okay. You have prepared this template yourself for the comparison.
Yes, sir.
This you have prepared yourself. I think this document that you prepared is very exhaustive, very useful. Like if you give it to the PGs, obviously to print out in the OPD, it is a very useful when you work hard. I think that information is very useful. You can use it in day to day. So I think that if you are presenting for others also, if you are presenting something that is exhaustive, okay, I think that there are some parts which you think are important but may not be, you may not be able to present in 30 minutes. So you can make a document like this. Maybe share this document in our group by email or WhatsApp group. That details this is the complete exhaustive detail. And in presentation, you can just mention the important things. It is not possible to read out all these. Although the information that you have presented or you have made this, it is very useful. Like somebody who can even PTSD, email, you can use. Okay. But there are two things. One is that when you're presenting, then after a time people will use it. Okay, so 30 minutes presentation. Out of this whole, what you are presenting, that you have to cut it. Okay. And the second thing is that the seminar that you are presenting. So what is the topic and what will come under? Because if you include things that are outside the realm, then it will become very exhausting. Can you please take me the first slide? I did not see the in the beginning described. Yeah. First. So we started with the disorders. Like we should have started with what is there in ICD10 under anxiety disorder, what is there in anxiety disorder under DSM5 and ICD11. These headings that you describe, I find it better where ICD10 and ICD11 are side by side and DSM5 is on the right. In other, you have presented DSM5 in the middle. So you first of all say what is there in anxiety disorder in ICD10. So they have taken some things away and they have added a few things. That is from where we start. Okay, OCD is now not under the disorders. Right? So from there you start, and you work very hard preparing this document. I can understand. But presenting in half an hour is a very tedious. Maybe you can share this. You have a word document of the session. You can share this in the book. It will be very useful for
presenting, putting this in a very meaningful essence. But you could have highlighted what are common in all these three. No need to read 3 times. You can only read it once.
Like panic attack description, the wordings may differ, but the description is same. In one diagnostic criteria, the frequency is different. Okay, then the where it is described may be different. Okay, so that is more useful rather than the difference in panic disorder, how it is described in ICD10 or ICD11. Okay. Agoraphobia is missing in ICD11. It's not described. Agoraphobia. Okay, but this is a very useful document. I think this is very useful for all the PGs.
Important is like agoraphobia, they have done away with and without panic attacks.
Yes,
it was an older concept.
Also, ICD10 which criteria have you described here? PCR.
Yes, sir.
PCR criteria. We use a blueprint.
Yes.
The guidelines.
Yes.
So, for example, in panic disorder, the frequency of attack is not described in ICD10. The guidelines that we use. Okay, it does not describe in that. In DSM, it is there. It is more easier to describe. Okay. So you work very hard, but by presenting, I think it would have been more useful. I think for others also, you make a very huge PowerPoint, but you find that the information is useful for others. You have collected it, you can share it in the group, and you can say that out of the time presenting, these points I will be covering, and others can refer from the document. You can make a write-up or a Word document, okay, before you make a PowerPoint, and share it with all the others. Like this information I have, but I will not do it in 15 minutes. To cover important things, you can cover. Other people can refer from the document. They can share it a day before or in the morning. So then read and come and say, okay, you covered it. But you're not going to speak it in the seminar because there is only so much that you can present.
It seems that ICD11 has just tried to work on DSM5 and other than that, they have taken away some classifications like hopefully also they have taken away predominantly
That it appears to be rather difficult. The approach why you get these criteria earlier, why you're removing them just because we can increase.
no scientific
Yes.
explanation, but they
So that we are only increasing reliability. That is the only thing that the disorders have a reliability between DSM and ICD. There is concordance, and between like remove those contentious criteria where there was problem in reliability. For example, bizarre delusions, schizophrenia, they removed like things like that where there was contention, like make it more objective sort of.
but still it seems that the classification they have now it has a strong scientific basis. It does that
It is
because
more
they were supposed to bring ICD, they were
yes.
everybody was expecting when the ICD11 becomes there, they'll have to make some changes. For the sake of making changes,
Not much change from ICD10 to see in terms of improvement. It is simply just a bit of
or
yeah. Yeah. You just remove from here, add there. Read it again and
The rest of the part will take later. You have to also design the presentations by the time required.
you've done a lot of hard work. See, we can see hard work is there. Your formatting is okay for reading somebody. For as a reference document is very good. somebody preparing for exam, somebody for daily work, it is good. For example, in the wards, like from which sometimes we ask questions. But this is a very good exhaustive document. For presentation part, you can just highlight. Okay, and concept is more important. Like usually the wordings are different, but the description of syndrome is what are the key differences that we need to know. Okay.
If you do it very well, you can actually write it up and publish finer differences between all the diagnoses, recent diagnoses. It's not available that crisply they are teased out the differences. Broadly, they are.
Thank you.
Okay, thank you.